Drugs used in peptic ulcers and gastrointestinal diseases. Peptic ulcers. Let us have a look at one case where David F. Carpenter complained of disturbed sleep at night and discomfort in daytime owing to abdominal pain, nausea, vomiting, and headache. These symptoms continued for around 2 weeks, and then David decided to meet a doctor. Upon telling his history, doctor recommended him endoscopy. Endoscopy revealed that David had peptic ulcer. So what is peptic ulcer? Ulcers which occur in stomach and duodenum are called as peptic ulcers. It is so named because these areas are exposed to the pepsin and gastric acid. Do you know why does this peptic ulcer occur? Your digestive tract is coated with a mucus layer that normally protects against acid. But if the amount of acid is increased or the amount of mucus is decreased, you could develop an ulcer. Hence, peptic ulcers occur due to the imbalance between the gastric acid and defensive gastric mucus. To understand this in a better way, we will see how hydrochloric acid is secreted in our body. Gastric acid is secreted through gastric parietal cells or oxyntic cells. Parietal cells are activated by acetylcholine, gastrin, and histamine via their own receptors located on these cells. From the blood vessels, carbon dioxide is diffused in the parietal cells and reacts with water under the influence of catalyst carbonic anhydrase and forms bicarbonic acid. Later, bicarbonic acid gets dissociated into hydrogen ions and carbonic acid. This carbonic acid is exchanged for chloride ion. Later, chloride ion along with potassium ion gets diffused outside into the canaliculi through the ion channels. Now, ATP powers the exchange of potassium ion and hydrogen ion into the canaliculi and forms hydrochloric acid. Drugs used for treatment of the ulcer are broadly classified into 4 major groups: reduction of gastric acid secretion, neutralization of gastric acid via antacids, ulcer protectives, anti-H. pylori drugs. Reduction of gastric acid secretion involves proton pump inhibitors, H2 antihistamines, ANTICHOLINERGICS, PROSTAGLANDIN analogues, proton pump inhibitors. Drugs which inhibit proton pump of parietal cells to stop secretion of gastric acid are called as proton pump inhibitors. The various proton pump inhibitors are OMEPRAZOLE, lansoprazole, pantoprazole, rabeprazole, and esomeprazole. OMEPRAZOLE is a prototype of proton pump inhibitor. OMEPRAZOLE is the powerful inhibitor of hydrochloric acid secretion. OMEPRAZOLE remains inactive at neutral pH in parietal cells. But at acidic pH, it turns into 2 charged cationic forms that react covalently with SH groups of the hydrogen-potassium ATPase or proton pump and inactivate it irreversibly. Hence, hydrogen ions are not exchanged further until and unless a new hydrogen potassium ATPase is synthesized. A new hydrogen potassium ATPase is synthesized every third day. Oral absorption of omeprazole is 50%. It is rapidly metabolized in the liver and metabolites are excreted in urine. Hydrochloric acid secretion is inhibited within 1 hour of administration, reaches maximum at 2 hours, half maximal at 24 hours and lasts for 3 days. Clinical uses of omeprazole. Duodenal and gastric ulcer disease. Zollinger-Ellison syndrome. It is a triad of increased gastric acid secretion, peptic ulcers, tumor of pancreas. Non-steroidal anti-inflammatory drugs induced ulceration. Helicobacter pylori associated ulcers. Proton pump inhibitors eradicate the bacteria by raising the pH of intragastric acid, which in turn lowers the minimal inhibitory concentration of antibiotics used against pylori. Gastroesophageal reflux disease. It is a disorder where lower sphincter muscles remain relaxed, allowing acid back into the esophagus. Adverse effects of omeprazole. It causes abdominal pain, diarrhea, and headache. In cases associated with H. pylori, it causes chronic inflammation of gastric body. Also, it causes gastric neoplasia. Long-term usage effects. Proton pump inhibitors increase risk of enteric infections due to bacteria like Shigella and Salmonella. They inhibit absorption of vitamin B12 and decrease calcium absorption, and aggravate osteoporosis. They also cross the placental barrier but are not teratogenic. Other proton pump inhibitors like esomeprazole, lansoprazole, rabeprazole have same properties of omeprazole but are more potent. Pantoprazole is equally potent but more acid stable. H2 antagonists. Drugs which block H2 histamines to reduce secretion of hydrochloric acid are called as H2 antagonists. Cimetidine, ranitidine, famotidine and roxatidine are the various H2 blockers. Cimetidine was the first to be introduced clinically. Cimetidine acts by blocking histamine-induced gastric secretion. They are highly selective and have no effect on H1 or H3 mediated responses. It causes marked inhibition of pepsin content and gastric secretion by reducing secretory responses to all other stimuli like acetylcholine, gastrin, insulin, alcohol. Oral absorption of cimetidine is adequate. Bioavailability is 60 to 80% due to first-pass hepatic metabolism. Elimination is through urine and bile, and elimination T-half is 2 to 3 hours. Adverse effects: dry mouth, headache, dizziness, bowel upset, rashes. At higher dose, CNS effects like confusional state, restlessness, hallucination. Also, gynecomastia, loss of libido, impotence, and temporary decrease in sperm count. It increases plasma prolactin and inhibits degradation of estradiol by liver. Uses: it can be used for duodenal ulcer, gastric ulcer. Healing rates are little lower when it comes to gastric ulcer, stress ulcers and gastritis. Zollinger-Ellison syndrome in high doses controls acidity. Gastroesophageal reflux disease afford symptomatic relief. Prophylaxis of aspiration pneumonia. When H2 blockers are given preoperatively, it reduces the risk of aspiration of acidic gastric contents during surgical procedures. Another H2 antagonist, ranitidine, is a non-imidazole and has several desirable features than cimetidine. It is 5 times more potent than cimetidine. No increase in prolactin secretion and hence no effect on sexual function and gynecomastia. No CNS effects. Overall incidence of side effects is negligible. Anticholinergics. Drugs which block the action of neurotransmitters, that is acetylcholine, are called as anticholinergics. Pyrazine, propantholene and oxyphenonium were more preferred because they do not cross blood-brain barrier and hence lesser side effects. Adverse effects: dry mouth, blurred vision, constipation, urinary retention. Next, let us talk about the last category falling under the reduction of gastric acid secretion. Prostaglandin analog. Prostaglandins are the lipid compounds having hormone-like effects. Prostaglandins have been found in almost every tissue of human body. Prostaglandins such as prostaglandin E2 and prostaglandin I2 are produced in the gastric mucosa. Prostaglandins act on gastric parietal cells. It inhibits gastrin release and hence inhibits further acid secretions. In order to reinforce the gastric and duodenal mucosal walls, it increases mucus secretions to protect the mucous wall from acid. Further, this process of reinforcing is buffered by increased bicarbonate. Now, you all know how a prostaglandin helps in reducing acid secretion. Let us discuss about prostaglandin analog. A compound having the same molecular structure as the prostaglandin is called as prostaglandin analog. Misoprostol, that is methyl prostaglandin E2 ester, is a classic prostaglandin analog used to reduce acid secretion. Antacids. Antacids are weak bases which neutralize the acid in stomach, thereby increasing the pH of stomach content. Antacids are given between meals because the presence of food in stomach can prolong the neutralizing action. Antacids are further classified into systemic and non-systemic. First, let us see systemic antacids. These are called as systemic because it has effects of acid-base balance on the whole body. Sodium bicarbonate and sodium citrate are the classical drugs which are used. These drugs neutralize the acid. On neutralizing the gastric hydrochloric acid, it forms carbon dioxide and sodium chloride. Carbon dioxide release promotes gastrin release, which causes rebound acidity. Formation of carbon dioxide in stomach causes distension, discomfort, belching, and risk of ulcer perforation. Absorption of sodium chloride increases sodium load, resulting into fluid retention in patients of hypertension, that is, high BP, chronic heart failure, and renal insufficiency. These are effective for healing of duodenal ulcers, but less effective for stomach ulcers. Let us discuss few non-systemic antacids. Those are called as non-systemic because they affect specifically the stomach acid-base balance and does not have effect on whole of the body. These are further classified as buffer type and non-buffer type antacids. Buffer type antacids. It includes aluminium hydroxide, magnesium trisilicate, and magaltrate. Both aluminium hydroxide and magnesium trisilicate neutralize to form aluminium chloride and magnesium chloride respectively. Silicon dioxide formed during neutralization reaction forms a gelatinous coating over gastric mucosa and prolongs the antacid effect. Aluminium chloride and magnesium chloride further reacts with intestinal bicarbonates to form aluminium carbonate and magnesium carbonate. Aluminum hydroxide binds with the phosphate of intestine. It results in the prevention of phosphate absorption. Also, it causes osteomalacia. Aluminum hydroxide leads to constipation and magnesium trisilicate causes diarrhea. Hence, both the preparations are given together as one formulation to avoid any effect on bowel movement. Non-buffer type antacids. Magnesium hydroxide and calcium carbonate are good antacid with prompt and sustained neutralizing action. Milk alkali syndrome. In the past, large quantity of milk was asked to be consumed along with calcium carbonate. This produced a syndrome characterized by headache, anorexia, weakness, abdominal discomfort, and renal stones. Nowadays, it is rare. Antacids are no longer used for its rebound acidity action, but it affords faster symptomatic relief in gastroesophageal reflux disease, but no sustained benefit. Ulcer protectives. Drugs which protect the ulcers from further damage are called as ulcer protective drugs. Sucralfate, colloidal bismuth subcitrate, and bismuth subsalicylate are the ulcer protective drugs. Sucralfate is an aluminium salt of sulfated sucrose. In acidic environment, it forms a sticky gel over the ulcer crater which acts as acid-resistant physical barrier. Dietary proteins and mucosal proteins also get adsorbed over this coat, forming another layer to provide resistance. All ulcer protective drugs heal the ulcer in a period of 4 to 8 weeks. Other uses of sucralfate. It can also be used for stomatitis, burn dressing, and bed sores. Anti-Helicobacter pylori drugs. Drugs which act against the Helicobacter pylori bacteria are called as anti-Helicobacter pylori drugs. Before we talk about the drugs, let us first see how these bacteria cause peptic ulcers. These bacteria get easily colonized in the acidic pH of the mucosa. It produces proteolytic enzymes such as proteases and lipases, which degrade the mucous layer, leading into chronic inflammation of gastric and antral mucosa, and ultimately ulcers. H. pylori is a risk factor for gastric adenocarcinoma and non-Hodgkin's lymphoma. To treat these ulcers, anti-H. pylori drugs are used, and they are as follows: amoxicillin, clarithromycin, metronidazole, tinidazole, and tetracycline. These drugs are given in combinations along with proton pump inhibitors for 1 to 2 weeks for complete healing of ulcer. As we have discussed all the drugs separately, let us summarize all the drugs. Approaches to the treatment of peptic ulcer. Drugs used for the treatment of the ulcer are broadly classified into 4 major groups: reduction of gastric acid secretion, neutralization of gastric acid, ulcer protectives, anti-Helicobacter pylori drugs. Reduction of gastric secretion is further classified into 4 categories: H2 antihistamines, proton pump inhibitors, ANTICHOLINERGICS, prostaglandin analogues. H2 antihistamines include cimetidine, ranitidine, famotidine, roxatidine, loxatidine. Proton pump inhibitors include OMEPRAZOLE, lansoprazole, pantoprazole, rabeprazole, esomeprazole. Anticholinergics include pyrazine, propanthyline, oxyphenonium. Prostaglandin analog includes misoprostol. Neutralization of gastric acid is classified under systemic and non-systemic. Systemic includes sodium bicarbonate, sodium citrate. Non-systemic includes magnesium hydroxide, magnesium trisilicate, aluminum hydroxide gel, megalderate, calcium carbonate. Ulcer protectives includes sucralfate, colloidal bismuth subcitrate. Anti-Helicobacter pylori drugs include amoxicillin, clarithromycin, metronidazole, tinidazole, and tetracycline.